I'm here today to address the issue of chronic pain and how integrative medicine can help is Dr. Todd Bourne. Dr. Bourne is a naturopathic physician, certified nutrition specialist, owner, and medical director of Bourne Investigative Medicine Specialists, PLLC. Dr. Bourne is also the medical wellness advisor for the International Medical Wellness Association and a key opinion leader for Augurex Life Sciences Corp. He's extensively published, has appeared on multiple news and national radio shows, and lectured as an expert for the National Psoriasis Foundation and the Arthritis Foundation. He lectures at medical conferences across the country and internationally. Dr. Bourne's clinical focus is utilizing integrative medicine to treat families of all ages who have complex chronic diseases with a strong interest in difficult and refractory cases of any condition and age. He sees patients all over the US and globally. It is my pleasure to welcome Dr. Todd Bourne for a discussion about chronic pain types and treatment options.
Thank you for that lovely introduction. I'm going to share my screen so everybody can see it. So I wanted to thank the National Psoriasis Foundation for inviting me to speak to you. I have spoken to your group before. It's been a number of years. I spoke on a different topic, just kind of naturopathic approaches to treating psoriasis and psoriatic disease. And these are my disclosures. And what I hope to teach and convey today really is about the different types of chronic pain and common causes, 6 major categories, treatment options, and really how multidisciplinary approaches can be utilized to improve overall health outcomes and quality of life, because that's really what it's all about, right? Is improving lives, decreasing pain. And I normally give this talk to healthcare providers, sometimes they say the civilians, so to speak, and it's usually about a 90-minute presentation. So I have 35 minutes to present to you. So it's going to be, we'll move pretty quickly, but really it's just the salient points of the slides and a 10,000-foot view of the information to let you know that there are options outside of pharmacotherapy. Pharmacotherapy should be used, but I use them a little more judiciously than my conventional brethren. So let's look at just some quick depressing factoids. And this data is from 2010. I really couldn't find anything that was newer that really kind of isolated really the points quite nicely, which it affects more than 100 million people in the US, 20% of outpatient visits, 12% of prescriptions, and it costs the United States about $100 billion a year in direct and indirect expenses. And these aren't data, it's certainly higher than this because it was 13 years ago, and it's also not data for those individuals who have their uninsured or underinsured, so they don't go to the doctor to get diagnosed. They just kind of tend to rely on just over-the-counter medications, although pain is a big motivator to get people in to see a doctor. Pain-related expenditures, again, it actually exceeds cancer, heart disease, and diabetes combined. You can see how expensive it is. And again, direct costs, lost wages, people missing work, how much it burdens the healthcare system, et cetera. And because the way the conventional medical model, the US model is designed, unfortunately, in the insurance-based system is that it's a fee for service. So it's the doctors have to see you quicker and quicker and quicker. So your patients, your appointments, obviously, as you all know, get truncated down. And it's just easier to write the script and try to figure out what's going on. And I can't say it any better myself, so I'll use this quote: "The use and misuse of opioids for management of chronic pain is a major concern, with problems arising from their multiple adverse side effects, drug dependency, drug diversion, and undertreatment of chronic pain symptoms for the fear of opioid abuse. Chronic pain is thus a major medical and social issue affecting the quality of life, individual patients, their friends, families, workforce, and society in general." So when we really look at these things, at least the way I see it, right, this holistic approach is that one of the first things I'm concerned about, or I kind of question, is what kind of pain is it? So is it neuropathic pain, right? Nerve pain? Is it musculoskeletal pain? Do you have an inflammatory condition like psoriatic arthritis? Do they have an infection? Like they got a tick-borne illness. They have some kind of arthropathy, which is a joint pain. So I need to understand, because opioids, for the most part, are not really anti-inflammatory. They just block your brain's perception of the pain. Mechanical and compressive, right? Do they actually have a compression fracture? Do they get in a car accident? Do they get a crush injury? Do they get a football injury? And most of the time when people end up having chronic pain, they're actually in multiple categories of pain. This is also key, right? Because pain is very subjective. Some people have very high pain tolerances and some people don't. Women tend to have high pain tolerances than men. So when people come in and we start talking about their pain and I'm trying to elucidate what kind of pain is it, what makes the pain better or worse, all the usual questions. But I'm also like, 1 to 10, 0 to 10. 0, you're in no pain. 10, you're in a lot of pain. What are you averaging and what gets you to 10? And I will ask them this, and I'll give them this scale. This is an international pain scale. And I'll look at the faces because they might say that my pain is 10. And I'm like, well, is it really a 10? And they'll say, oh, well, 10 is worse pain. It means I'm bed rest required. No, I'm actually probably more like a 6 or 7. It helps me understand how much pain they're in. It also helps them start to normalize that pain, what really is the amount of pain that they're in. And then you got to really look at it: thorough evaluation, comprehensive history of presenting illness, physical exam, standardized pain scales. My practice for the last 5 years is 100% telehealth. So I don't see patients in person physically anymore. It's all via HIPAA compliant programs. That's how I see people all over the world. So I can't do much physical exam anymore, but I don't, after 13 years of practice, don't need much. And I just refer out for other things like physiatry. You got to assess psychosocial factors. For example, if they're really stressed out all the time, they're not sleeping well, they're in a toxic relationship, they're in a toxic work environment, their pain is going to be worse, right? Because the mental aspects of pain, really, with the somatization. What have you tried? What's worked? What's not worked? And why? And I hear this a lot from people. It's like, well, yeah, I tried turmeric. I tried curcumin. It didn't do anything. Well, one of the first things I ask them, they try it for their pain, is how much did you take? How many times a day do you take it? How often did you take it? How long did you take it? Where did you get it? Because I did look at the National Psoriasis Foundation website, and there is a misnomer saying that the dietary supplement industry is not regulated by the FDA, and that's not true. It is actually regulated by the FDA. It's poorly enforced. That's the difference. That's why you can get a lot of supplement companies out there, and most honestly, they're just not very good. They're garbage. So if you have the good stuff that really works, it's far more effective. We'll go through that. So again, just kind of, flying through these slides, diagnostic workup. I'm really kind of known as being a vampire because I see a lot of complicated patients, a lot of autoimmune disease, and I'm trying to figure out what is actually going on so I can make inroads to improve the outcomes without having to use a whole lot of steroids, or I can start tapering their steroids, tapering their methotrexate, tapering their use of the NSAIDs. So you got standard testing, you got to look at inflammatory markers, hormones, and these are steroid hormones. And remember, our steroid hormones, these are physiological steroids, not pharmacological, say like prednisone or betamethasone. So you can actually use these when they're low, or even say insufficient, so not frankly low, to help to control chronic pain. In 13 years of treating thousands of people with autoimmune diseases and chronic pain, it's very, very rare, unless they're in the beginning stages, that I actually see these hormones normal. They're usually pretty low because of the fact that a lot of times they're on long-term steroids, you get adrenal suppression, but there's lots of other reasons. Looking at nutrients, many of these might be because they have neuropathic pain, and then getting it covered well by insurance using these codes. So now, based upon what they're telling me during their history, I'm starting to think, okay, we got to get a little more advanced, possibly. Do they live in an endemic area that has a lot of tick-borne illnesses like New England or the Midwest? Now, ticks for Lyme disease, for example, has been found on every continent but Antarctica. So I'm looking at tick-borne infections. I'm looking at treating the gut, small intestinal bacterial overgrowth, which is a breath test. I've seen a lot of people with some bizarre pain syndromes, and they've been referred to me by other clinicians. And it turns out that, after we do all the rule outs, well, I'm like, you might have this. We treat this, and lo and behold, they do better. Heavy metals more tends to, when you start thinking of neuropathic pain or neurological pain, and or if I'm doing, and I have my diagnosis and I'm pretty sure that's what's going on, and I'm doing a therapeutic interventions, and they're adherent to that program, but they're not responding. Something's interfering with why they're not responding, even if it's a medication. So I might start considering heavy metals and mycotoxins, which come from molds that many people clear. They're basically like the spores on the molds, much, much smaller than even a mold, and they can cause problems with people. It's called the great mimicker, similar Lyme disease. And then genetics. And the reason I run HLA-B27 people with chronic pain, particularly, and also looking at anti-nuclear antibody, looking at autoimmune disease, is just because someone, for example, is HLA-B27 positive. It does not mean they have ankylosing spondylitis or psoriatic arthritis, but just because they're negative doesn't mean they don't have it. The reason I run these is that if they are positive, and they do have one of these conditions right here listed, an HLA-B27 positive condition, they actually have a worse prognosis. So the person will have a hastening of their disease. So it's important to be more aggressive so you don't get that long-term joint destruction. Other genetics, if someone, say you're trying to rule out celiac disease, if someone's on a gluten-free diet, doing serology testing for tissue transglutaminase and deaminated gliadin antibodies, you're testing antibodies to gluten. So if they're avoiding gluten, you can have falsely negative results. Genetics, you're born with these and they don't change. So I run these HLA, DQ2, DQ8, and there's a particular lab that I use. I have no affiliation, called Prometheus. Insurance covers it. And they will actually do the subtypes of the HLA. And they'll tell you the percentage of likelihood that that person will develop celiac disease or is likely to get celiac disease, 50%, 80%. So that also helps them to be more adherent to gluten-free. But look at all these other diseases that are associated with HLA, right? The HLA DQ2, DQ8 phenotypes. Diabetes type 1, Hashimoto's, Crohn's, ulcerative colitis. And this may be why some people who have these diseases, but they don't have celiac disease, they respond better on a gluten-free diet. It's because they have some genetic propensity not to be able to degrade gluten and gliadin proteins. And then there's this DR3, which we're not talking about today. So this is an important little factoid, right? Because it's a negative feed-forward cycle, right? People who are in chronic pain, they're more likely to have depression and anxiety, about 75% of people, which then further exacerbates their pain syndromes. So is it the chicken or the egg? I usually will ask people, before all this pain stuff happened, did you tend to be a more anxious person, tend to have some depression? And they'll tell you, yeah, I've always been kind of a worrier. They also have insomnia, usually because of the fact they can't sleep because of the pain. And then they have fatigue. So you can see how everything is compounding one another. They can't sleep, which is worsening their pain. And then they're tired, which is worsening their pain. So if you actually get them sleeping better, get their energy improved, and treat their mood, the pain also improves. So if you actually treat them all, you can see this multi-pronged approach, you get better outcomes. And people who have very complex chronic pain syndromes, it's not only me who feels this way. I mean, the data shows this, and we'll show some studies here, that it really needs a multidisciplinary team. And this doesn't mean I'm shunting them to all over the place so they're doing nothing but being in a doctor's office all the time. But I will bring them on as needed. I'm like, sometimes, I don't really know what's going on with your pain. I really need you to see a physiatrist. And I love physiatrists, right? These are medical doctors and osteopaths who are musculoskeletal specialists, and they're not surgeons. So they're trying to keep you out of the surgeon's hands. So if they say, you really need surgery, let's get you orthopedics, you probably do. Versus if you send them to an orthopod, that's their bread and butter, right? They're going to try to convince you to cut you and fix things. Not all of them. A lot of times they will send you to PT, but my experience is most of the time they're ready to start doing some surgery, even if it's, like debridement for some osteoarthritis of a shoulder. So I'm a big fan of these physical therapists, occupational therapy, but getting someone to the right specialist who can make an accurate diagnosis, and then we can then get treatment. Because sometimes people with chronic pain, we're like, we don't even know, and you just throw the kitchen sink at them and wonder why it doesn't work. So let's talk about what is typically done, and many of you who have psoriatic arthritic disease have been down this road, or you're currently in the road because you're being worked up and you're kind of punted in the system. So the conventional approach is we're either going to give you pharmacology, physical therapy, behavioral therapy, neuromodulation, intervention, and surgery. And if you actually look, if you even combine these for non-cancer pain, the journal Lancet, one of the most prestigious journals in the world, they're actually showing only a 30% reduction in pain. Not typically very stellar. So then you have pharmacotherapy, and that's the most widely used because it's the quickest. And look at the classes of drugs. Again, I'm not knocking these. There's a time and a place for everything. They just need to be used more judiciously. So you got non-opioids, opioids, alpha-2 androgens. I mean, the list goes on, muscle relaxers, et cetera, the DMARDs, the steroids. Particularly people who have autoimmune disease, it's like, well, let's start you on a DMARD or a biologic, we'll kind of pick our favorite one. And then hopefully you tolerate it and it works and you don't build tolerance, you don't build antibodies, you don't have side effects. Okay, we can go to a different class. We'll give you a TNF blocker. Oh, that didn't work. Well, let's give you a JAK inhibitor. Let's give you an IL-17. Let's give you an IL-23A. You see where this is going. Not very scientific and strategic, systematic approach like I like to do it. And here's the standard of care, right? Here is actually how you're supposed to have meds prescribed. Mild pain, non-opioids with some adjuvant therapy. Mild to moderate chronic pain, right? The more pain you have, then you start intervening. Because of what happened a few years ago with that came into the media of the overuse and abuse and overprescription of opioids, people are using these more judiciously, but I still see them prescribed, say, too easily, too readily when someone doesn't really need an opioid. Despite significant progress, chronic pain remains refractory to treatment. Only 1/3 to 2/3 of patients reporting a greater than 50% pain relief. Moreover, first-line drugs, NSAIDs, and opioids are associated with adverse dose-limiting side effects, dependence, and tolerance. So this verbose way of saying is that you get the drug, but the drug, the body builds tolerance to it, has a lot of, and you need more and more of it. You can also become physically dependent, as we all know. And once you get too high of a dose, then you start worrying about some pretty severe consequences. That's also why I like pain specialists, right? If someone has chronic pain, because they really know how to use these medications versus the primary care provider that doesn't typically have advanced training in these kind of medications. Here's a study that just came out in Lancet in July, which was actually surprising even to someone like me who tends to be a little more skeptical about any intervention. They showed that opioid analgesia for acute low back pain and neck pain, not chronic pain, in a randomized placebo-controlled trial to the gold standard, actually did not work. It was no more effective than placebo. But what are people getting prescribed all the time? Acute pain, chronic pain, opioids. Again, time and place for everything. So here's my world, right? The integrative approach. And studies here, even out of the Journal of Rheumatology, showed that when you're using multiple therapies, you actually have improved outcomes and you get much greater than that 50%. And you can usually get people's pain significantly under control. And I love how this guy looks like he dropped a hammer on his thumb. So maybe he's in some chronic pain as well. And the key for me is evaluation of the cause. So first of all, what kind of pain and what is the cause of your pain? Is it nociceptive pain? Do you have damage to the tissue? Is it neuropathic pain? Do you have a herniated disc? Do you have a crush injury that's pressing on your nerve? What is it that's going on? Why do you have these neuropathies? Do you have diabetes, et cetera? You got to find the cause. In naturopathic, one of our tenets is tolle causa, treat the cause. Integrative interventions, right? And we'll just fly through these just to know. It doesn't mean you should be going out and self-medicating and, saying, oh, Dr. Bourne's slide, I should try all these things. It's not really very advisable because it might backfire on you. I just want to let people know, the general public and any healthcare providers, that there are literally limitless options. When people come and see me for chronic pain, autoimmune disease, and they've seen everybody, I'll tell them, and they're feeling despondent and desperate, I'll say, look, you will get tired of seeing me before I run out of options. And that's generally very, very true, because it'll take me a long time to run out of options for you. And if I haven't gotten any, inroads in, say, 6 months, I'm usually going to end up referring them to another doctor, not necessarily to someone for a workup, but for someone for treatment, because I might be missing something. So you got hydrotherapy and balneotherapy. So everybody knows what hydrotherapy is, right? Alternating hot and cold, things like that. Balneotherapy is more used in Eastern Europe and has been around for centuries. And that's kind of where they go in. They're using different types of water, different types of bath, different types of salinity. And these are, I've been to Europe and I've been to their bathhouses, not just for, relaxation. Like here's one. I mean, who wouldn't be relaxed sitting in a place like this? I think this is Iceland. But showing this is actual conventional therapy. Doctors refer people to these clinics for treatment, these spas, because they're like, let's try all these things before we just start giving you a bunch of NSAIDs that damage your kidneys, damage your, give you ulcers, have cardiovascular effects long term, damage the liver, et cetera. Physiotherapy is just any manual therapy, and that's a laundry list: infrared, low level laser, right, chiropractic, the TENS units, the list goes on and on and on. They're very effective. And even so much in 2017, the American College of Physicians said low back pain, you should be doing spinal manipulation, heat massage, and acupuncture before anything else. But yet that's their guidelines and that's rarely followed. And then you got electrotherapy, right? E-stim, ultrasound, low-level laser, those kind of things. I'm not a huge fan of this E-stim units. I mean, I'm sorry, the TENS units, because those are the little boxes you have, you put on an area of pain. They only work as long as they're being turned on. They're not like interferential and some of these electrotherapy instruments that actually have long-term positive effects. And the previous speaker was had big on diet, and here's my stint on diet, right? There's a lot of evidence that the anti-inflammatory diet, which is just, whole foods, plant-based diet, Mediterranean diet, no artificial colors, flavorings, no sugars, eating a healthy diet, improves outcomes. And here was a study that came out of Cleveland Clinic a few years ago where they either gave people a sham diet or the allergy elimination diet, and that includes removing the most commonly suspected foods that cause inflammation. And there is a difference between a food allergy, a food sensitivity, and a food intolerance. They are not the same thing. So for example, a true food allergy is where you eat, the seafood, the shrimp, and your face blows up, or you get a scratchy mouth, or you get hives all over, you become anaphylactic. That is a type 1 IgE-mediated hypersensitivity reaction where you need, diphenhydramine and an EpiPen possibly if you become anaphylactic. A food intolerance is not mediated by the immune system. You do not get extra gastrointestinal manifestations. In other words, you eat the gluten and you get a bunch of gas and bloating. But that's mediated by an enzyme insufficiency or deficiency. It's not an allergy. Then there's the world that a lot of people live in, are food sensitivities. Those may or may not be mediated by the immune system. So that's why you have you can have celiac disease, but it's called non-celiac gluten sensitivity. You might get IgG mediated antibodies, and you can get delayed reactions. And the only way to really know those is the allergy elimination diet is the gold standard. You can also do IgG food testing, but the evidence for that is best in chronic migraines, IBS, and eosinophilic esophagitis. But I could tell you again, the thousands of people I've had with autoimmune diseases and chronic pain, ultimately, at one point, they will go through the allergy elimination diet, and I have them give them a diet diary, and you will see outcomes. Psoriasis improves, pain improves, inflammation improves. It's because those foods they are sensitive to, and they may or may not be made by immune system. Even in this study, they showed a 30 to 40% reduction in pain with the allergy elimination diet. That's better than standard therapies of conventional therapies. And then there's homeopathy, right? Another great thing, because homeopathy has no interactions and it has no side effects, and it's been around for almost 200 years. And the way humans work, right? If it doesn't work, we would get rid of it. And even here in the Lancet, they said that homeopathy is more than just a placebo effect. But I can tell you again, if you want to have people stop their flares before they go into flare, mitigate flares, you give them their homeopathic medicine, and it stops pretty much 100% of the time, stops them going into a flare or mitigates it substantially. And here was a study, right? Because everybody likes studies, particularly conventional docs. They're just like, well, is there any proof? Here's just one study where they had a bunch of surgery patients and they gave them arnica or NSAIDs. And here you can see that arnica was just as effective as the anti-inflammatories with no side effects. And we know the problems with NSAIDs, at least long-term use. What about botanicals? This is where naturopathic medicine can shine really well, is because the advantage of botanical medicines, right, is that they tend to be multi-mechanistic. So they work on multiple mechanisms versus many conventional drugs usually are just mono-mechanistic. And many conventional drugs, we don't even know how they work. Just look them up. It'll say, suspected mechanism of action or complete mechanism unknown. So when people say, oh, you don't know how naturopathic or natural therapies work or herbs work, I said, sure we do. I mean, here's studies all over the place, and you don't know how your medications work. But there are classes of these. So you can give people the analgesics. You can give people antiarthritics. There's more antiarthritics. And what's nice is that some botanicals have affinities for different areas of the body. So if someone's got low back pain or joint pain, I might start giving them something like Harpagophytum percumbens, which is devil's claw, cat's claw, ginger, right? I mean, these are very, very effective and very, very low side effect profile. And many times the reason people say, well, these don't work is because they're not taking enough of it. So if someone has psoriatic arthritis and they're in chronic pain, using 500 milligrams of a really low absorbed, low bioavailable turmeric isn't going to do it. For prevention, that's one thing. You're starting to getting into like the 3,000 milligram dose of super bioavailable forms of these herbs. And then again, you got the antispasmodics. And a lot of times to get enough into people, I use tinctures, liquids. Otherwise, they're just taking 16 pills a day and the pill burden is a bit much. So, and I'll mix these. The The pain herbs are usually pretty horrible tasting. But again, pain's a big motivator. I tell people get some pomegranate juice or some Concord grape juice, and you're going to take a teaspoon of this mix 3 times a day and add a whole bunch of herbs in there, and it works usually pretty quickly. There's adaptogens and nervines. Adaptogens are good because they help with that stress component, and some of these now are showing, like Withania, which is ashwagandha. A lot of people recognize that one. They're showing efficacy in chronic pain syndromes, probably by modulating certain neurotransmitters that modulate pain. And then the immunomodulators, these are for people that I use a lot when they're on, say, a DMARD or a biologic, and it works pretty well. They might be coming in for me for breakthrough pain, or they tolerate the drug really well, but they're always sick because their immune system's depressed. Well, then we start talking about, well, don't mess with the med because it's working, but let's get it so you can not be sick all the time and catch every cough and cold that's going around the room. Then I start thinking of immune modulators. There is some concern that if you're someone with autoimmune disease, you give them immune stimulants, that it's going to exacerbate their immune system. That's theoretical. We haven't seen it in humans. So I pulse them anyway, just err on the side of caution. I'm like, take these Monday through Friday, or the cold and flu season's coming up. But there's also immune modulation versus immune stimulation. And these are immune modulators. They modulate how the immune system works. So they're not overly stimulating them like a bunch of polysaccharides or something. What about vitamins? Yes, vitamins do work. And again, they're at much, much higher doses than you think about. And people will freak because they'll be like, this is 2,000% of my daily value. Right, because we're not doing the daily value and the RDAs that are set by the government agencies. Those are the minimum amount of a nutrient you need to prevent a particular disease. Like 10 milligrams, for example, of vitamin C, ascorbic acid, to prevent scurvy. Well, we're not pirates anymore. We don't get scurvy, but you can use much, much higher doses, like 1,000 milligrams 3 times a day for acute viral infections, and studies prove that, mostly in children and athletes, but still works nonetheless. Vitamin E, right? And here's the mechanisms. I'm not going to read them to you and put you to sleep, but you can see vitamin D. And the reason I'll just pause on vitamin D for a minute is that I see vitamin D grossly overprescribed by most clinicians, conventional, functional medicine, integrative medicine, naturopathic medicine. The human body has natural shutoff mechanisms for vitamin D. And these studies that have been done in Hawaiian lifeguards, where they don't give them any sunscreen, they stick them out in the sun for 45 minutes all summer, then they put the sunscreen on, and they'll measure their blood levels. Their blood levels rarely, if ever, go above 45 nanograms per mil because the body doesn't need more vitamin D than that. It just shuts it off. It produces metabolites, so it binds up the active D. Most of the studies out there, right, they're all retrospective studies. There are observational studies. And, I know there's D experts out there that disagree with me, but once you start getting into this, like the 80s and 90s and 100, which people erroneously believe they should be on, autoimmune disease or not, anti-aging, whatever, you're actually more likely to get arterial sclerosis, hardening of your arteries, kidney stones and bladder stones. And that's usually from hyperabsorption of calcium. But again, you don't need to be blasting people way above that. And it is, a fat soluble vitamin, so you also got, and it's activated in the liver, so you got to give it time to show up in the blood tests. But it is very important. I'm not saying don't give it to them, but pair it with vitamin K2, not K1, K2, and it helps balance out calcium effects. But you're really not going to get any greater benefits from 35 to, or 45 to 60. There's no evidence for it when it shows harm, actually. And here's some studies that prove my point. We got minerals, right, that are very important. Boron, calcium, magnesium, particularly in chronic pain. I love giving people calcium, magnesium before bed. It's calming, helps them sleep better, improves their pain pictures. There's amino acids, and it doesn't mean I'm giving everybody everything at once. I'm like, okay, first let's find out what you have, what kind of pain, what's the cause of the pain, and let's do these couple things first, And I'm usually doing multidisciplinary physical therapy, maybe some chiropractic, some nutrient support, maybe some injections, and the list goes on and on. And then there's essential fatty acids, right? Again, a lot more than one would normally ever think of because we're treating chronic pain. And you can make these work like steroids, by giving people as much. In the media now, you're seeing some evidence of atrial fibrillation with high dose omega-3 fatty acids. It's not that common. I've done this for 13 years and I haven't seen it, but it does make me a little more cautious with giving people massive doses for prolonged periods. But typically what I'm doing is giving people massive doses, talking 5, 10 grams, which you can really only get in liquids of a high quality fish oil. I'll give that to them for a few months. And once we get pain under control, I'm tapering down, also watching for easy bruising or bleeding, and then adding in these other essential fatty acids because they also help with pain syndromes. And I usually rotate the oils every 3 months to work on different cytokines. Then there's these other ones, right? They have good evidence for, neuropathies, glutathione, just because your body becomes depleted with glutathione. It's the most important antioxidant. I usually give it to people at bedtime, particularly if they're on a lot of medications. I'm like, because your liver is just overloaded and you'll see their liver enzymes go up. And I'm like, well, we got to balance all this out. One of my favorite things, now we're talking about resistant cases, proteolytic enzymes, and I use this a lot, and I just purposely threw in a whole bunch of studies because I like proteolytic enzymes. They're plant-based enzymes. You can also get them as animal-based. And the key to these is they have to be taken away from food, and they need to be some kind of enteric coating so they don't get degraded by the stomach acid, and they get released in the small intestine, and they bind up immune complexes, and they work very well. There's only one brand I've found, I have no affiliation with that company, that I can get enough into people that they don't get nauseous, but lots of studies in rheumatoid arthritis, osteoarthritis, cancer, induced pain, and they're very effective. And I've just used these. I had a patient who had rheumatoid arthritis, just giving her proteolytic enzymes in the allergy elimination diet. She went off methotrexate and her TNF blocker, and then then we started tapering on prednisone. So she'll be off prednisone pretty soon. Let's look at hormones. Again, we talked about that in the beginning with me testing these hormones. And I like this schematic because it's easy for everybody to visualize that you have cholesterol. And then all of our steroid hormones, testosterone, estrogen, pregnenolone, they're all made from cholesterol. They're all cholesterol backbones. So when I have patients who say maybe on statins and their cholesterol is just driven into the ground, but they're not diabetic and they haven't had an adverse cardiovascular event, I'm like, why is your cholesterol so low? They don't even have enough cholesterol to make these hormones. So I'm like, well, why do we got to reconsider, why are you on so much statins? And then statins can cause fatigue and muscle cramps and things like that, muscle pain, worsening their pain syndromes. So I'm dosing these, and some of these are over the counter. Again, I wouldn't recommend you just grabbing DHEA or pregnenolone unless you need it. And they tend to be either steroid hormones, so there's poor oral absorption, so they need to be some kind of fat and micronized when they make small molecules. And then these are a prescription. And I will test people on all these with chronic pain. And then eventually, we'll probably end up giving them some hormones so they feel better, and then taper them off the hormones. I don't like leaving people on hormones unless they need it. And I don't like leaving it on long term. I get a lot of patients. I have one right now who has psoriatic arthritis, and she was like, she's a nurse practitioner, and she's like, well, what about cannabidiol, CBD? I've heard that can be good. And here's kind of the spiel on CBD, right, is that I don't like just CBD because, number one, that's not what's found in nature, and that's not what's found in humans. We have multiple receptors, CBD, CBG, CBC, CBA, CBB. Most of the studies just in the last 5 years, right, are on CBD, but we're understanding a little bit more how some of these other receptors interact. But you still need something that is standardized to CBD to know how to dose it. So these doses are really 10 to 160 milligrams. Short course, you can go above that, but there was a good study here that just came out in the Regulatory Journal of Toxicology and Pharmacology, where they have a nice synopsis. If you have liver disease, no liver disease, if you're thinking about getting pregnant, like what's a safe range? And in my experience, those who tend to be a little more anxious tend to do better with CBD when it comes to pain control. And I usually start people with 10 milligrams breakfast and 10 milligrams of dinner with the fish oils, because that works on the body's endogenous endocannabinoid system. So you get it's called the entourage effect. You're getting basically the one enhances the other, so you can go on a lower dose. And really how it works is it depends on the receptor target throughout the body. But they can be very good, but again, very low absorption, so they need to be in some kind of fat for your body to absorb it well. And drawback, expensive, and insurance doesn't cover it. So for me, in these tough cases, right, I'm like, people are an onion. I'm peeling away layers. They're 50% better. They're 60. They're 70. Well, I want to get you 100, right? That's your goal. That's why you hired me. Nobody should live in chronic pain. My wife has ankylosing spondylitis, so I know what it's like to live with people who have chronic pain. I'm a big fan of the topicals, right? The creams, the lotions, the potions, the gels, the patches, pharmaceutical otherwise. These are tissue cell salts that I've just seen work really well in neuropathic pain. We talked about neurological pain and the proteolytic enzymes. And then psychological, right? We start talking about people and it's depressing to be in pain all the time, right? I mean, well, I'm like, well, depending on their personality, I might say, have you thought about a support group or psychotherapy or, cognitive behavioral therapy, hypnotherapy, something, because the brain's receptivity to pain, if you start undoing there's neuronal connections, pain improves, mood improves, sleep improves, positive feed-forward cycle. And again, liver kidney support, because if you look at acetaminophen, right, it's the #1 cause, which is Tylenol. It's the #1 cause of acute liver failure in the United States. And when I was rotating in the emergency rooms in my residency, there were our seniors, a couple of them came in because what ends up happening is that maybe they got some chronic pain, so they're on some Tylenol 3 with some codeine, and then they were taking some Tylenol for their pain, which Tylenol is not even that great of a pain reliever. It's a great antipyretic, but not until you get to like these 2,000, 3,000 milligram levels does it even do much for pain. And now you're starting to get into that threshold that you shut down your liver. I don't really even like it. I end up switching people to them, but giving people liver and kidney support so they process these medications better. And again, treating the gut, because the gut microbiome, as we're understanding more and more, modulates a lot of our immune system, modulates a lot of our neurotransmitters, which is pain sensitization, pain interpretation. So you got to clear it. Particularly, I have never seen a skin condition, any skin condition, autoimmune or otherwise, that didn't have a gut component to it, or a food component. So once we clean up the gut, once we get rid of the food sensitivities, intolerance, allergies, people will be 50 or 60% better. In my clinical experience, studies show this as well, just by those 2 interventions alone. Then we start thinking about mitochondrial dysfunction, regenerative therapies, which again, these are people that I'm like, they're 85% better, 90% better, but they've been seeing me for 8 months. I'm like, we might start thinking about some of these other things like proline-rich peptides, prolotherapy, ozone, prolozone. These are injection therapies. They are safe if you have someone who's certified in them. Drawback is you usually need a fair amount of them. I use a lot of sports medicine docs for these, and insurance does not cover them. And you might need 12 treatments of them and pony up some pretty big dough. So that's another conversation we need to have. We're kind of getting here to the end, so hopefully I give you plenty of time to answer questions. These are medications that I like to prescribe. So again, I do prescribe them, right? Judicious use of prednisone. You got to stop that gorilla, who's already pushing that buff down the hill or getting ready, right? They're like the Tasmanian devil to the 3-year-old like mine coming in, just rampaging. It's prednisone time. We got to hit the brakes. And then muscle relaxers, I do use them a fair amount because I got to get people to sleep. Short course, thinking about addiction potential, I might give them 15 days worth, a week worth, no refills. I'm not going to just be like, yeah, here's a month, here's an open prescription for a bunch of, addictive substances that, again, these aren't anti-inflammatory, but I got to undo things while we do all these other naturopathic things. I'm a big fan of diclofenac. It's an NSAID, comes as a large patch. You can cut it. It's really good for people that have like isolated areas of pain because you can't cover them. And terrible oral medication causes all sorts of problems, but great as a patch with little to no systemic absorption. The nausea, some people are in so much pain, they're taking so many things, they're nauseous, so then they can't even take the meds, they can't take the supplements, they can't take the herbs because they're too sick. So the homeopathics aren't working, I'll just start giving them. And NSAIDs, right, I do use NSAIDs. It's amazing what happens is when you get people off of their naproxen or their ibuprofen, etc., their meloxicam, and then you do all these other things, and then just occasionally breakthrough pain. It might be like, take 600 milligrams of ibuprofen or take 500 milligrams of naproxen. They're just like, oh my God, I couldn't believe how much this medication worked this time. I was on that for a year and didn't do anything. It's because we fixed all the other things and you also went off of it until your tolerance went down. And then there's LDN, which you can't give it if someone's on an opioid because it blocks opioids, the receptors, and so it blocks opioids effects. I've really seen this work better for neurological disease and people with multiple sclerosis. I haven't seen it do all that. I know there's lots of studies in psoriasis and rheumatoid arthritis, but I personally haven't seen it work all that well. So it's not something I go to right away. So here, really, what is that, whirlwind tour I gave you, the crash course on chronic pain, right? You got to treat the cause. You got to find the triggers. Then it's always going to be a food or foods. It's going to be some kind of stressful thing, an sensitivity, intolerance, one of those kind of things. And we got to remove those. Now we stop the flares because they're not triggering their flare anymore. Multifaceted, multi-targeted, multi-team, multi-mechanistic approach works best for these, not just monotherapies. And you got to be systematic in triage. Otherwise, it's just really convoluted. It's really overwhelming. And people are like, whoa, my treatment plan's got 13 things. And I could barely get out of bed. No, I can't do all that. Be systematic, triage, right? Sometimes people see me, even for the first visit, I'm like, we're going to give you prednisone. And this is why, this is how much I'm going to give you. And then we're going to do these things. Don't be afraid to bring in collateral help. A lot of doctors get possessive and they don't want to send anybody out to anybody, but the patient it'll pay yourself in spades because they're going to tell everybody how great you were and you send them to someone who's able to help or diagnose. And then look at the dosages, right? You got to do a lot more in the beginning. And then when people's pain goes down, then you kind of taper it to less and less. And so from that, we'll open it up to Q&A.
Wow, thank you so much, Dr. Bourne, for your presentation. As a patient population that commonly suffers from chronic pain, this is such valuable information to have.
Right.
So as you said, it's now time for our Q&A session. The first question we had was from Raghu Singh, and it was requesting if you have a preferred reference to do proper food elimination.
Someone, excuse me, like me, you're a dietitian, someone knows how to do it. But there's a lot of decent resources. It's pretty simple. So due to the allergy elimination diet, you remove the most commonly inflammatory foods with people for 2 weeks, because that's enough for it to clear out of the system, and then you challenge them. And then the inflammatory foods, if you Google it, it'll come up. But it's soy, corn, gluten, dairy, and eggs. So life kind of sucks for 2 weeks when you're avoiding all of these things, but now with all of
A question in the chat from
gluten-free
Gene
and all these
Dixon.
foods that taste better, it's
What is
pretty
your
easy.
opinion on
It's pretty easy to
osteoporosis
stay away
meds
from
like
for 2 weeks.
Fosamax?
And then it is important to keep a journal, because then you're going to challenge a food, but you have to wait 72 hours after challenging that food. And the way to challenge it, you want to do it in its whole form. So if you're going to challenge gluten, you get 100% whole wheat organic toast or bread, and you're going to eat it with breakfast, you're eating it with lunch, and you're eating it with dinner. And then you wait 3 days for a reaction, because there are delayed sensitivities. And if so it's 4 days total, if you don't react to anything, then you're unlikely to react to that food. You can consider it safe. And those reactions can be anything. If your joint inflames, you get a headache, you get a bunch of diarrhea, that's a positive challenge. If you eat the whole wheat toast for breakfast and all of a sudden your joints flare up, there's no reason to that's a positive reaction. You don't need to keep eating it and keep torturing yourself. The only time it can be a bummer is if you do the allergy elimination diet and you start reacting to a food every time you challenge a food. It can make the allergy elimination diet go on for months. And when that happens, I usually just tell people, if you've reacted to your 3rd food in a row, you should not keep reacting. Just stop it. There's something else going on. IgG food testing can be helpful, particularly with children, because you can get a much better view of what's going on, because children are hard to put on the allergy elimination diet. They go to school, they eat other kids' food, they don't like it. And also IgG testing can be helpful because you can test for 100 foods at once. Doing the allergy elimination diet will take you a lifetime. But really, you need either a nutritionist or a naturopathic doctor or someone who's familiar with it to walk you through. But the journal is key. I have a little Excel spreadsheet that has items at the top, and then they just journal it. Particularly men, right? We're not very self-aware sometimes. So when they bring back in the journal, they'll say to me, I did the whole thing, I didn't notice a difference. And then I'll go through the journal. I'm like, but here when you challenged dairy, you told me you had a bunch of gas and bloating and your eczema flared. Oh yeah, I guess that did happen. So it is important to keep the journal and try to find something that's pretty simplistic online, but most of them are pretty straightforward, but they do need to be removed for 2 weeks and then challenged one at a time, waiting 4 days.
Another question / comment from Raghu Singh, reading lots of content on vitamin K2 to reduce the harm from vitamin D. Vitamin D is now sort of unavoidable given the amount of food it's fortified into.
Yeah, that's a good point. So, but most of the fortified foods are ergocalciferol, which is vitamin D2, not vitamin D3. Vitamin D2 is about 30% as effective as vitamin D3. And we don't even know the bioavailability of it. Vitamin K2 is important, and it depends on if it's MK7 versus MK4, right? They're different as far as milligrams versus micrograms, and I'll spare you those details. But they should be taken together. But once people start getting into these vitamin D levels, like they've been taking 10,000 for months, I use, or 25,000, and vitamin D is very genetically driven. I've seen people that can get to 45 nanograms per mil. Also, to where we live, I live in the Pacific Northwest, right? During the winter, it could be a sunny day, but you still won't produce D, versus living like in Arizona or something, or Florida. But once you get really, really high amounts, right? And some people only need 1,000, some people need 5,000. Once your blood levels become a certain level, it doesn't matter how much K2 that person consumes. It doesn't seem to offset those arteriosclerotic adverse effects from that amount of D. And there's some other problems with having that much D. I had a patient that was sent to me, and he had some leg cramps, and he's got celiac disease and fatigue. He's a teenager. His vitamin D was 110. And I was like, why is your vitamin D so high? And he said, well, that's what my functional medicine doctor said it should be. And I was like, well, one reason you probably have muscle cramps is because of the fact that you're absorbing too much calcium, so you're kind of getting some tetany and fasciculation. So we had him stop his vitamin D for a month, and those went away. Wasn't rocket science, but anyway, yeah, they should be used in combination. But once you get your blood levels too high, it doesn't matter how much K2 you take, still have adverse events long term.
A question in the chat from Jean Dixon. What is your opinion on osteoporosis meds like Fosamax?
So I treat a lot of osteoporosis, right? And that's one of the side effects for people on long-term prednisone. They're fine. They're not great, right? I mean, there's data when people are on things like the bisphosphonates more than 5 years, they have your bone is actually, the bone that you're laying down is more porous than if you weren't on the medications. So the key to using things, the bisphosphonates, or some of these newer medications that seem to work on, osteo class activity or mitigating osteoblast, the breakdown of the bone, you still need to build bone. In order to build bone, you need a number of things. Bone is a living tissue, so it's calcium and magnesium and zinc and boron, and I have a whole osteoporosis thing a talk that I give, as well as a supplement I give people, because just taking the medication will not build up your bone and a stronger bone. And then also, then it's particularly people who are severe osteoporotic, right? They got the Dowager hump, and they step off a curb and they'll get a compression fracture, right? The concern is that you fall, you break a hip, and then we all know the health outcomes once you break a hip. I mean, it's not great. Is then also looking at a person's house, right? Making sure there's not things that people can trip on, rugs. Really, that's a key component. That's a non-drug way. And then doing weight-bearing exercise. So it needs to be weight-bearing, the supplements, and sometimes a medication, depending on how bad their osteoporosis is.
Another question from the chat from Chris Bennett. What is your recommended dosage of glutathione?
All depends on the person's size, their weight. I typically give and glutathione is another poorly absorbed molecule. So you got to get one that is high bioavailability. If it's in a liposome, or it's in some kind, if it's acetylated, acetylglutathione is better absorbed than L-glutathione. I usually give people 1,000 milligrams at bedtime. And the reason I like giving it at bedtime is because bedtime, when you sleep, that's the body's ability to regenerate. That's when nerve growth factor, brain-derived neurotropic factor is high. And so I'm helping that along by giving it something like glutathione. In young kids, it's hard to get them to swallow. Glutathione doesn't taste good, right? It smells, any of these thiol molecules like lipoic acid, glutathione, they smell like burnt tires, rotten eggs. You can actually get cream, a transdermal cream, they're by compounding pharmacists, that I like to put creams in the axilla because there's a lot of lymphatic tissue that absorbs right in, so you can use those. But if it's oral, I'll give people 1,000 milligrams at bedtime.
Thank you so much again, Dr. Bourne. This has been a really fantastic session. Thank you so much for being here.
Sure. Thank you. Take care.